Today, we're discussing an important statement that appears throughout the heart failure guidelines. Hypertension is the most important modifiable risk factor for heart failure with preserved ejection fraction, or HFpEF. What exactly does that mean? Why is hypertension considered the driving force behind HFpEF? And most importantly, what can clinicians do to prevent it? Let's get started. What is HFpEF? Heart failure is not a single disease. It is a syndrome in which the heart cannot meet the body's demands. There are two major types: heart failure with reduced ejection fraction, HFrEF, where the heart cannot contract effectively, and heart failure with preserved ejection fraction, HFpEF, where the heart contracts normally but cannot relax properly. Patients with HFpEF often have a normal ejection fraction of 50% or greater, yet they experience symptoms such as shortness of breath, fatigue, exercise intolerance, swelling, difficulty lying flat, and recurrent hospitalizations. Many people assume that if the ejection fraction is normal, the heart must be functioning normally. That is simply not true. The heart has two jobs. First, it fills with blood, then it squeezes that blood out to the body. The problem in HFpEF is not squeezing, it is filling. It's too stiff to fill up with enough blood before it squeezes. Why hypertension matters? Hypertension is the leading cause of HFpEF worldwide. Unlike age or genetics, hypertension is something we can diagnose, monitor, treat, and control in most people. That is why it is called the most important modifiable risk factor. Every heartbeat has two phases. The first is systole, when the heart contracts. The second is diastole, when the heart relaxes and fills with blood. Patients with HFpEF develop problems during diastole. The ventricle becomes stiff. Instead of relaxing like a balloon, it behaves more like a thick rubber ball. It can still squeeze normally, it just cannot fill efficiently. How high blood pressure damages the heart? Imagine pushing open a heavy door. If you have to push against that heavy door every second of every day for years, eventually your arm muscles become larger. The heart responds exactly the same way. High blood pressure increases afterload, the resistance the heart must pump against. To compensate, the left ventricle develops thicker muscle. Initially, this is an adaptive response, but over time, the thickened muscle becomes stiff. Microscopic scar tissue called myocardial fibrosis develops. Eventually, the ventricle cannot relax normally. The result is elevated filling pressures. Blood begins backing up into the left atrium. Pressure then increases in the lungs. Patients begin experiencing shortness of breath with exertion. As the disease progresses, they develop pulmonary congestion, exercise intolerance, fatigue, and repeated heart failure admissions. The progression, think of HFpEF as a continuum. Long-standing hypertension becomes left ventricular hypertrophy. Left ventricular hypertrophy becomes myocardial fibrosis. Fibrosis leads to diastolic dysfunction. Diastolic dysfunction raises filling pressures. Elevated filling pressures produce symptoms. Those symptoms become HFpEF. This process usually develops over many years. That is why prevention is so important. The echocardiogram tells the story. When evaluating a patient with hypertension, the echocardiogram often reveals changes before symptoms appear. You may see left ventricular hypertrophy, left atrial enlargement, grade 1 or grade 2 diastolic dysfunction, increased filling pressures, elevated pulmonary artery pressures, normal ejection fraction. These are warning signs. They tell us the heart has already begun remodeling. What is remodeling? Remodeling refers to structural changes that occur within the heart. In hypertension, remodeling includes thickened ventricular walls, increased collagen deposition, fibrosis, loss of elasticity, progressive stiffness. Initially, this remodeling is adaptive. Eventually, it becomes maladaptive. Once fibrosis develops, reversing it becomes much more difficult. This is why early blood pressure control matters. Blood pressure goals, current hypertension and heart failure guidelines generally recommend a target blood pressure below 130 over 80 millimeters of mercury, provided treatment is well tolerated. Lowering blood pressure reduces left ventricular hypertrophy, stroke risk, chronic kidney disease progression, myocardial infarction, development of HFrEF, heart failure, hospitalizations. However, blood pressure should not be lowered excessively. Overtreatment can produce dizziness, falls, kidney injury, and inadequate organ perfusion. Treatment should always be individualized. Other modifiable risk factors. Although hypertension is the strongest contributor, HFpEF is often the result of multiple interacting conditions. These include obesity, diabetes, chronic kidney disease, coronary artery disease, atrial fibrillation, obstructive sleep apnea, sedentary lifestyle, and smoking. Each condition contributes inflammation, vascular dysfunction, or myocardial stiffness. When several are present together, HFpEF develops much more rapidly. What should clinicians ask? When evaluating a patient with HFrEF or a patient at risk, consider these questions. How long has the patient had hypertension? Has blood pressure truly been controlled? Are home blood pressure readings available? Is there evidence of left ventricular hypertrophy? Does the patient have diabetes, chronic kidney disease, sleep apnea, or obesity? Has an echocardiogram shown diastolic dysfunction? What medications are currently being used? Are lifestyle modifications being reinforced? These questions help identify patients before irreversible remodeling occurs. Prevention is the best treatment. One of the greatest opportunities in cardiovascular medicine is preventing HFpEF. We cannot change aging. We cannot change genetics, but we can aggressively identify and treat hypertension. Every clinic visit is an opportunity to prevent the next hospitalization. Every controlled blood pressure reading represents less stress on the heart. Every patient educated about sodium restriction, exercise, medication adherence, and home blood pressure monitoring is another opportunity to prevent progression. Key takeaways. Let's finish with 5 important points. Number 1, HFpEF is primarily a disease of impaired relaxation rather than impaired contraction. Number 2, long-standing hypertension is the leading cause of HFpEF. Number 3, uncontrolled blood pressure causes left ventricular hypertrophy, fibrosis, and diastolic dysfunction. Number 4, hypertension is the most important modifiable risk factor because effective treatment can delay or even prevent HFpEF. And finally, early recognition, aggressive blood pressure control, and management of associated conditions such as obesity, diabetes, chronic kidney disease, atrial fibrillation, and sleep apnea remain the foundation of HFpEF prevention. Thank you for joining me on this episode of Hypertension Resistant to Treatment. If you found today's discussion valuable, please subscribe, leave a review, and share this episode with your colleagues. Together, we can improve hypertension management, prevent heart failure, and help our patients live longer, healthier lives. Until next time, remember, control the blood pressure today to protect the heart tomorrow.